everybody. This is going to be the MDC 2 Exam 2 recording on ABGs, oral, and upper GI conditions. So without further ado, we're going to go ahead and get right into it. Let's go ahead and make this there. Alright, so firstly, I definitely recommend that you go in and practice your ABGs because the more you do them, the better you're going to get. So I have some links here on the doc from Nurse Labs. I made a little Kahoot challenge based on the study guide. So I found this Quizlet for an exam. Unfortunately, my Quizlet decided it was going to go and go through copyright because I guess they think NCLEX style questions is cheating, but we're going to see what I can do. I might post something on another site later today. And then your medical surgical success book, the chapters on ABGs, and then like the GI stuff. You'll find some good practice questions because all your exams going from here now forward are going to be NCLEX style questions. So definitely learn your material and make sure you practice your material. And you can find the medical surgical success book in the library. You can also look up the Saunders book. Saunders' book also has some good questions for prep. But anyways, let's start material. So the first thing that you're going to need to know are your normal ranges of your ABGs. Remember, pH is 7.35, 7.45. PaCO2, 35 to 45. Bicarb, 22 to 26. And PaO2, 80 to 100. So remember, the lower number is going to be more acidic, and the higher number is going to be more alkaline or basic, except for CO2. So the more carbon dioxide you have, the more acidic it's going to be because CO2 acts as an acid. So the more you have, the more acidic you're going to be. So that's why when you have a ABG with for example, maybe you have a PaCO2 of 50. That's going to be more in your acidosis rather than if you have a PaCO2 of 20, you're going to be more in alkalosis. So those are some things to keep in mind. And now your abnormal ranges, remember you're going to either have acidosis or alkalosis, meaning you're going to be more acidic or you're going to be more basic. So pH is going to be, for acidosis, pH is going to be lower than 7.35. PaCO2 is going to be higher than 45. Remember, PaCO2 is an acid, so the more you have, the more acidic it's going to be. And then your bicarb is going to be lower than 22. In alkalosis, you're going to have your pH be above 7.45. Your PaCO2 is going to be lower than 35, so meaning you have less acid in your body and you are more basic. And bicarb is going to be high, of course, because you're in a basic state. And then PaO2 is going to be abnormal when it's below 80 or above 100. So the only times we'll see like a high PaO2 is when you're in an alkalosis state. So there may also be abnormalities with your pH. Your pH can also be split into 7.35 to 7.4 as being acidosis. If you come across a fully compensated pH problem, and then 7.4 to 7.45 is going to be that alkalosis state. If you're in, if you have a normal pH, but it's fully compensated, so, and it's a higher pH, so it's going to be in alkalosis, but it's going to be fully compensated because that pH is in a normal range. Remember that the ultimate pH, like normal balance, is going to be 7.4. Now we're going to go ahead and look at how to solve our ABG balances. So first, we always look at the pH. We have to determine if it's acidic, alkaline, or normal. If it's in a normal range, we may need to take that step further. We need to determine if it's more acidic. As I said earlier, it's going to be between 7.35 and 7.4, or if it's alkaline, between 7.4 and 7.45. It's going to help us determine that compensation. We need to know if it's going to be fully compensated or partially compensated or uncompensated. So looking into that is going to help us a lot going forward. After that, we're going to look at our PaCO2. If it's below 35, it's going to be more alkaline. If it's in normal range, it's going to be between that 35 and 45. Or if it's above 45, you're going to be in acidosis, so it's going to be acidic. Then we look at our bicarb. We need to determine if our bicarb is below 22 or if it's more acidic in a normal range, which is going to be 22 to 26, or if it's above 26 or it's going to be more basic or alkaline. So we need to see that too. So remember, you can use Rome, you can use tic-tac-toe, you can use arrows. However you're comfortable with doing your ABG imbalances, do it that way. Once all readings have been determined, remember you can use your Rome method or you can use tic-tac-toe. Remember, respiratory opposite is that Rome. Remember, pH and CO2 levels will be in opposite directions. So, for example, if you have a pH of maybe 7.3 and your CO2 is 60, remember that's going to be opposite. So you're going to have your pH arrow going down and your CO2 arrow going up. So the arrows are pointing in opposite directions. That's how you mean it's a respiratory opposite. Metabolic equal means that your pH and your bicarb is going to be in the same direction. For example, maybe your pH is 7.3 and your bicarb level is 10. So both of those arrows are going to be pointing down, indicating your patient's in metabolic acidosis. So that's just the way you can determine it. It's all depending on how you prefer to do your ABG imbalances. After you're done determining your ABG imbalance, whether it's respiratory acidosis, respiratory alkalosis, metabolic acidosis, and metabolic alkalosis, you're going to look at your PaO2. Your PaO2 is going to be helpful in determining what's going on with compensation. So PaO2 is the amount of oxygen that's in your arterial blood. It's going to be very prominent in our respiratory clients because with our respiratory clients, our patients may be getting too little PaO2 or too much PaO2. We need to look and determine if there's enough oxygen getting into the lungs or not. If this is lower than 80, we're going to know that there's not enough perfusion of oxygen within the arterial blood and that there's difficulty breathing somewhere, so the lungs are impaired. Or if it's high, that means we might be hyperventilating, so we're letting off too much CO2 and we're taking in too much oxygen. So we need to know about that as well. After we're done getting all our measurements in, we will now determine if the imbalance is going to be fully compensated, partially compensated, or uncompensated. So this part can be a little challenging, but if you look at it this way, it can be a little bit easier to determine. So compensation occurs when there is an acid-base imbalance and the body attempts to correct an abnormality within the other body system. So remember, your pH is going to be affected first. That is the first buffer that's going to be affected. We need to see if your pH is going to be normal, abnormal, acidic, or alkaline. Then we're going to look at the PaCO2 and bicarb. So whichever value is abnormal, that is your compensation. So for example, if you're in a patient that has, let's say that they have, this is their ABG, 7.3. PaCO2 is 60. And let's say their HCO3 is 18. So this patient, you can obviously see they're in a state of respiratory acidosis because their pH is below 7.35. Their CO2 is above 60. Or no, it's 60, so that's way above normal range. and their bicarb is below 22. So there is some compensation going on here. So your compensation for your respiratory is going to often be in the kidneys, or if it's a metabolic concern, it's going to be in the lungs. So your patient's going to be like ventilating or not ventilating. So that's how you look about compensation. So let's go into whether how this is going to play off. So with our fully compensated ABGs, so the body has placed their pH back into a normal range. So your pH is going to be, with your fully compensated ABGs, between 7.35 and 7.45. Okay, cool. How do I determine what acid-base imbalance is? Remember what I said earlier? You have to look at whether or not it's more leaning towards the acidic side or more towards the alkaline side. So maybe somebody who has a fully compensated ABG, their pH is 7.37. We're going to know if that's a fully compensated ABG, that pH is in a normal range, but it's leaning more towards acidic, because an acidic pH within a normal range is going to be 7.35 to 7.4. However, there's going to be other systems with abnormal ranges. So usually maybe both are going to be abnormal. So your pH may be normal in a fully compensated ABG, but your HCO3 and your CO2 will be both abnormal. So this is how a fully compensated ABG will look like. 3.7. That is what a fully compensated ABG looks like. This is normal, but it's leaning more towards the acidic side. This is definitely acidic, and this is definitely acidic. So this is a fully compensated ABG because both the lungs and the kidneys are working to get their body back up to a normal state. Partially compensated ABGs is when all three levels are going to be abnormal, meaning that the pH is compensating and both the PaO2 or CO2 and the bicarb are also uncompensated. So respiratory system and kidney systems are both compensating to get that pH back to a normal range. So this is how you may see a partially compensated ABG. So 7.3. This might be an example of a partially compensated ABG, because you can see this is very much, this patient's in a respiratory acidotic state, but look at their HCO3. Their HCO3 is below the normal range, meaning that they're in a state of acidosis here. So this is partially compensated because you can see that the lungs and the kidneys are trying to get that pH back to a normal range. Uncompensated is going to be also very pronounced. So the body is not in a state of compensation yet, but there's abnormality of the pH in this is going to be either the PaCO2 or the HCO3, but they're not going to be both compensated. So this is how one of your uncompensated ABGs will look like. I'm just going to pull the one up top. This is how a respiratory acidosis uncompensated ABG will look like. See, your pH is below 7.35, your CO2 is above 45, and that bicarb is in a normal range. It's between 22 and 26, it's 24. So that shows that patient is not in a state of compensation yet, so there's an abnormality of a pH and either the PaCO2 or HCO3. In this situation, the PaCO2 is abnormal and the HCO3 is normal. Okay? The best way to figure out ABGs is to just keep practicing, keep looking at your charts, using your Rome, using your tic-tac-toe method, watching certain videos on how to do it. It's whatever you need to do to get to know how to do these ABGs. you can do that. That's my recommendation. So now we go into our buffers. So remember how I stated earlier about how things can compensate for each other? Well, first, your chemical is going to be the first line of defense against a problem. So your pH is going to either release hydrogen ions or bind to them. So this is why we have that pH change very quickly. So it's going to respond quickly to changes in the pH. Our next line of defense is going to be that respiratory buffers. So respiratory buffers control the level of hydrogen ions within minutes in the blood through the control of CO2 levels. Because of chemoreceptor-related changes in the level of CO2, signals are sent to the brain to alter the rate and depth of respirations. Perhaps the patient will be hyperventilating or hypoventilating. With hyperventilation, the patient's just going to be blowing off too much CO2. With hypoventilation, the patient's going to take in too much CO2 and not let out a lot of CO2. The third line of defense is our kidneys. So the kidneys are much slower to respond. That's why you're going to see often changes in the respiratory system first before the kidneys. But it's most effective with the longest duration, so it's going to last longer. They're going to control the movement of bicarb into the urine, and the bicarb can either be reabsorbed or excreted. That's why it takes a little bit of a while, because the kidneys have to take in and take out a lot of things. And then here's some more information on pH regulation. Remember, it's the expression of the balance between CO2 and bicarb that's regulated by the lungs and the kidneys. So the greater concentration of hydrogen, the more acidic the body is going to be, so the lower the pH. The lower the concentration of hydrogen ions, the more alkaline the body fluids will be, and the higher the pH will be. So when excess carbon dioxide is produced, the equation will shift to the right, causing an increase in hydrogen ions and a decrease in pH. That's why you see in our respiratory acidosis clients, you're going to see that respiratory opposite. Those arrows are going to go in opposite directions, because when more hydrogen ions are produced, hydrogen's an acid. So the more acid you produce, the higher your CO2 level is going to be, and the lower your pH is. That means that there's more free hydrogen ions, and if the pH of the CO2 level decreases, there's going to be fewer free hydrogen ions, so it's going to be more alkaline. So that's just kind of a way how to think about it as well. Next, we're going to go into each of the imbalances and what exactly is going to cause them, what you might see, some signs and symptoms, and how we're going to treat this. It's very important to identify these respiratory and metabolic imbalances so we know how to properly treat them and recognize those signs and symptoms, because there's many disorders here that can be detrimental because of an ABG imbalance. And as nurses, we have to be able to properly treat these abnormalities. So firstly, we have respiratory acidosis. So what is it? pH lower than 7.35, PaCO2 greater than 45, bicarb may be in the normal range unless it's compensated in some way. Your PaO2 is going to be less than 80, meaning that the patient's not getting enough oxygen into the lungs. There's going to be CO2 retention, increase in hydrogen ions. The pH and CO2 levels will be in acidic ranges, and there's going to be more acids in the body. Some of the causes of respiratory acidosis include hypoventilation, because the patient's not breathing effectively. Maybe there's an obstruction. Maybe the patient's in respiratory depression. COPD patients, the COPD patients, their lung compliance is very low, meaning they're holding on to more acids and not getting enough oxygen in, because their lungs can't work effectively as normal lungs can. Our asthma patients may have trouble getting CO2 in and out because of bronchoconstriction. Pneumonia patients, they have a buildup of mucus causing obstruction of the lung areas and inability for the lungs to filter in and out because of that infection. Again, respiratory depression can be caused by various different factors: anesthetics, drugs, opioids, poisons. Fluid overload may cause imbalances, tumors, edema, and stroke because there's an increase of fluid. Increase of fluid makes your breathing levels decrease, meaning that the patient's going to be holding on to more acids. An inadequate chest expansion, if the chest can't expand correctly, nothing can get out of the chest. So meaning more is going to be kept in. So that's going to be caused by various things like muscle weakness, obstruction, alveolar capillary blocks, and mechanical ventilation that's improper. It may also be seen with those who have sleep apnea and obesity, because with sleep apnea patients, their lungs aren't working as correctly to get air in and out while the patient's asleep. That's why often many people who have sleep apnea use a CPAP machine so they're able to ventilate properly while asleep. And obesity, because in an obese patient, they may not be able to expand their lungs properly as a person who has a healthy BMI would. So that's why they may be subject to this type of imbalance. Here are some signs and symptoms of respiratory acidosis. Vital signs, you're going to have tachycardia, hypertension. You may have bradycardia, hypotension as it worsens. The pulse is going to be bounding. Often they're going to be in fluid overload. You may have VFib, delayed electrical conduction. They're may have a lot of EKG changes. May have initial anxiety and confusion. They might be tired. They might be in a comatose state. Their respiratory pattern is going to be ineffective. It's going to be weak, and it's going to be shallow. They're going to have variable respirations, but usually they're going to be slow and depressed. Their skin may be pale, cyanotic, or dry because they're not getting enough O2 into their lungs, meaning that the blood can't carry the oxygen to the organs it needs to be. So that's why they're going to be pale, they're going to be blue, they're going to be dry, because there's not enough oxygen getting to the in the bloodstream. So they can't, so their skin's going to be affected in that way. Treatment, the first thing we want to do is improve gas exchange. Remember to sit the patient up. Give them incentive spirometer, because that's going to help increase the lung capacity. You can give a bronchodilator. You can give anti-inflammatories or a mucolytic. You can give O2. However, with O2 patients that have respiratory acidosis, a lot of them have COPD. So remember, we never want to hyperoxygenate the patient, especially if they have COPD, because their lungs don't have enough compliance to handle large amounts of oxygen. Maybe we'll give them a liter, but not anything more than that. Just enough to get their enough oxygen in and CO2 out. We can do pulmonary hygiene. We can give them ventilation support. We can adjust our settings if needed, and we can prevent complications. Next, we have respiratory alkalosis. So how this may look is the pH may be above 7.45. The PaCO2 will be less than 35, meaning they're not holding on to a lot of CO2, but they're releasing too much. Their bicarb may be in a normal range unless there's compensation occurring. Their PaO2 may be between 80 to 100 or even above 100. And respiratory acidosis is because there's a loss of CO2, whether it be, usually it's from hyperventilation. So they're breathing too fast. So some of the causes, of course, hyperventilation, fear and anxiety because the patient's often breathing very fast. Mechanical ventilation, maybe there's a problem with the settings. Aspirin toxicity can cause respiratory alkalosis because of the way the medication is working in a toxic state. It can be caused by high altitudes because there's not enough oxygen in higher places. For example, you go in the mountains, you're going to have a hard time breathing because there's no oxygen available. So the patient may start breathing really fast. Shock, early stage acute pulmonary problems, diarrhea because you're losing acid. Some signs and symptoms, you're going to have tachypnea, so breathing really fast. You're going to have an inability to concentrate. You're going to have maybe numbness, tingling, tinnitus, possible loss of consciousness. You're going to have tachycardia. You may have some dysrhythmias and rapid, deep respirations with the respiratory system because the patient is breathing too fast and they're releasing too much CO2. Some of the treatments, if possible, we want to instruct the patient to breathe into a paper bag because it's going to help place the CO2 back in the body, and that's what we want because they're not holding on to it. We can give oxygen if needed. We need to decrease our anxiety. We may need to give them anti-anxiety agents. We can use rebreathing techniques. We can use guided imagery. The goal here is to pace the breathing and decrease the level of stress in the body. Because usually with that, it's going to place that patient back into a normal acid-base imbalance or acid-base balance, because the cause here is usually too fast of a respiration. Now we move into metabolic acidosis. So, what is it? You're going to have a pH less than 3.5. Your CO2 may be in a normal range unless there's compensation going on, and your bicarb is going to be less than 22. So there's an overproduction of hydrogen ions, under-elimination or underproduction, or over-elimination of bicarb. So some of your causes can be excessive oxidation of fatty acids, like in DKA or in our malnourished patients. It can be caused by hypermetabolism, heavy exercise, seizures, fever, hypoxia, ischemia, or excessive ingestion of acids, such as ethanol or methanol intoxication or aspirin. So remember, with our aspirins, our two acid-base imbalances are going to be key, are going to be metabolic acidosis and respiratory alkalosis. Those will be on the exam, so I suggest you know those. It can also be caused by kidney failure, pancreatitis, liver failure, dehydration, and diarrhea, which is going to be key, because when you have excessive diarrhea, you're losing too much acid, meaning, or too much base. Sorry. If you're losing too much base, your body's going to be placed into, okay, well, she can leave later. It's going to be placing your body more into an acidic state. Remember, acidosis kind of sounds like acidosis, meaning diarrhea can cause it. So, little hint there. That's how I remember it. It's a good way to remember it. So, signs and symptoms. One key signs and symptom you'll have with your, metabolic acidosis, you're going to have hyperkalemia. So, you're going to have too much potassium. Potassium is an acid and will increase when the body is in a state of metabolic acidosis. You can have vasodilation. You can have dysrhythmias, especially since your patient's also in a hyperkalemic state. And hyperkalemia can cause abnormal heart changes. There can be hypotensive. Their pulses may be thready. They may have slow pulses. They may be weak. Hypotension and tachypnea will occur. They may have a headache. They may be tired and confused. They're going to have those rapid deep respirations, aka your Kussmaul respirations. Their skin may be warm, flushed, dry, and pink. They may have a high blood sugar if they're suffering from TKA. They're going to have depressed CNS receptors. They're going to have lethargy, confusion, stupor, coma. They're going to have hyperreflexia, skeletal weakness, and paralysis potentially. So what we need to do here is we need to treat the cause, which is very important. We can give hydration. We're going to put them on strict I's and O's. Seizure precautions, because we don't want the patient to go into a seizure. We can give insulin to treat DKA, antidiarrheals to make us hold on to more base, bicarbonate if we need it, and definitely treat the cause. Lastly, we have metabolic alkalosis. So metabolic alkalosis occurs when the pH is above 7.45, the PaCO2 is in normal range unless there's compensation going on, the bicarb is going to be above 26, so we have too much bicarb going on. So there's going to be an increase of bases, or a base excess or decrease of acid. So some of the causes are from oral indigestion of bases or like antacids. It can also be from blood transfusions or sodium bicarb IV infusion. It can be from TPN. One key sign and symptom that is going to come with metabolic alkalosis is your vomiting. So kind of like ack. Like you can kind of like hack up. That kind of sounds like vomiting. Hack, alkalosis. So we're not going to listen to me hacking up anymore, but vomiting is a very prominent cause of why someone's in metabolic acidosis. Another common cause is too much suctioning. So maybe if our patients have metabolic acidosis, one of our treatments is going to be, let's not suction them so often, unless we need to. It can be from too much cortisol, too much aldosterone, or from diuretic use, because when you use diuretics, you're getting rid of hyperkalemia, you're getting rid of acid. So when you pee out the acid, you're going to have an abnormal imbalance. So that's why you may be in metabolic alkalosis. Some signs and symptoms of metabolic acidosis or alkalosis is going to be hypocalcemia or hypokalemia. You might have dizziness, confusion, twitching, tingling, increased heart rate and respiratory rate. You might have tachycardia. You also might have hypotension. You're going to have those dysrhythmia problems. You might have numbness, tingling, muscle weakness, hyperreflexia, increased anxiety, irritability, seizures. You might have those checks and Trousseau signs because of the hypocalcemia. You might have paresthesias. For your respiratory, you're going to have ineffective breathing. Neuromuscular, you're going to have cramping, hyperreflexia, weakness, seizures, high heart rate, hypotension. You might have an increase in ditch toxicity. Okay. Treatment for metabolic alkalosis is you can prevent further losses of certain imbalances, certain ions. Remember, you always want to treat your cause. You can restore fluid balances, monitor for changes, provide safety, modify or stop suctioning. You can give IV solutions, drugs that promote hydrogen ion excretion, antiemetics to help with the vomiting. Remember, you don't have to suction as often if needed. And that's where you can have mixed imbalances. So one imbalance may cause another. It just depends on the condition. It may be because of cardiac arrest, TKA, COPD, and often your mixed imbalances are going to be more severe, so you must treat both. Again, here's going to be your care of patients with aspirin toxicity. Aspirin toxicity can cause respiratory alkalosis and metabolic acidosis. So the first sign of aspirin toxicity is going to be hyperventilation, and then metabolic acidosis will occur when there's an increased amount of lactate in excretion of bicarb to compensate for the alkalosis. The patient may also have vomiting, fast breathing. They may have a high fever due to fluid loss. Seizures, coma, edema, and cardiovascular collapse may also occur if there's severe poisoning. Here are some helpful hints. Remember, acidosis kind of sounds like acidosis, which is a common reason why diarrhea results in an acidosis state. Alkalosis, remember, alkalosis, that kind of sounds like hack, maybe because of vomiting. Think alkaline occurs when the stomach is losing too much acid. Remember, you can use ABG, Rome, tic-tac-toe, check marks, whatever you need to do to help determine that ABG. Okay, let me see. I want to go over. Okay, so I'm going to end it here. Tune in for part 2, which is going to go over our oral problems. Oral and part of our GERD. Okay?